My name is Amer Zeidan. I'm a professor of medicine at Yale University and the chief of Hematologic Malignancies Division at Yale Cancer Center. So just as a quick background, so bexmarilimab, which is the antibody we are testing in this study, is an IgG4 antibody that's directed against a receptor called cleaver-1. So what is cleaver-1? Cleaver-1 basically is a scavenger receptor that's present on the surface of the macrophages and is involved in antigen basically uptake by the macrophages, as well as basically indirectly through involvement with the adaptive immune system with the T cells as well. And this cleaver-1 has been shown to be actually increasingly expressed in patients with cancer in general, but in particular with patients with MDS and AML. And what seems to kind of be doing is that it increases the anti-tumorigenic macrophages. So basically it suppresses the macrophage activity against cancer cells. And through the development of antibody against cleaver-1 called bexmarilimab, this will convert the macrophages to a pro-inflammatory state, which allows them to increase the activity against the tumor cells, but also it can activate the immune system through the T cell adaptive response. And there's also some data that it might target blasts directly through cell energy production. So the trial that looked at this one, called Bexmab study, had, I think, a kind of a patient-centric design that included a phase 1 with dose escalation and a phase 2 with dose optimization. So in the phase 1 part of the study, frontline patients with MDS as well as refractory relapse MDS and AML after HMA failure were enrolled, and all the patients received a doublet of azacitidine plus bexmarilimab. The drug was given at 3 different doses, 1 milligram, 3 milligram, and 6 milligram every week. Azacitidine was given at its regular weekly 7-day in a row schedule every 1 month. And the phase 1 dose escalation was based on a Bayesian design. And subsequently, after the dose initially was selected, this went through a dose optimization phase, which looked at comparing the 3 milligram and the 6 milligram per kilogram dosing, and it enrolled, the dose optimization part enrolled primarily in patients with HMA failure with high-risk MDS or frontline diagnosed patients with high-risk MDS using a Simon stage 2 design. So I think the study kind of showed important updates in terms of the activity and the safety of the drug. So what was presented in ASCO and additional details will be presented in EHA 2025, focused on a total cohort of 53 patients. 21 of them were tested in the frontline setting with high-risk MDS, and 32 of them were tested in the relapse refractory setting with high-risk MDS. The patients basically were typical of what we see in the community, with a median age in the 72 to 74 range. All of them had high-risk disease. The patients in the HMA failure cohort had exposure to at least HMA and potentially additional agents like venetoclax, and some of them had prior transplant. I would note that, that many patients in the frontline setting as well had TP53, which we know makes MDS kind of more aggressive. And what we have found is that bexmarilimab was well tolerated in the patient population. When we looked at the safety cohort, the total 53 patients, we saw that the rate of discontinuation related to bexmarilimab related adverse events was low at only 2%. And there were no bexmarilimab related deaths on this study. The rate of immune related adverse events was also quite low at 3.7%, with a maximum grade 1 and grade 2 events, both of them noticed in the relapsed refractory MDS patient population, primarily infusion-related reactions and Sweet syndrome. The most common adverse events that were seen were related to blood count suppression, some fatigue. Again, all of this is expected within the context of patients with high-risk MDS. The efficacy data, I think, was quite good. What we kind of concluded out of this dose optimization part of the study, that the 3 milligram per kilogram had the best balance between activity and safety in terms of kind of the dose to take forward and subsequent development. what we saw in terms of efficacy in the frontline setting is that we found that the combination had a composite CR rate of 50%, which is quite promising in the frontline setting of the 20 patients who were efficacy evaluable using the 2023 IWG criteria, which focuses not only on blast reduction, which is important, but also importantly on count recovery. And in the relapsed refractory setting, which is a very difficult patient population to treat, generally have poor outcomes and no approved drugs really in this setting outside of IDH1 inhibitor ivosidenib for only 5% of patients who have this mutation. So in this patient population with very limited options, we find a composite CR of 16% using the IWG 2023 criteria and an overall response rate of 47%. And importantly, we saw good activity in patients with TP53. And also the median overall survival in the relapsed refractory setting was 13.4 months, which is better than what is typically seen in the relapsed refractory MDS after HMA failure, which is generally in the range of 6 to 9 months. So I think overall we are kind of excited about this early efficacy data, and we also saw evidence of immune activation with bexmarilimab, as well as some evidence of correlation between cleaver-1 expression and seen responses. So I think the story is coming together well about the safety and efficacy of this antibody in combination with azacitidine, and justifies going forward with more advanced testing of this combination. I think the main takeaway is that this antibody is certainly well tolerated. The side effect profile is manageable, and early efficacy both in the frontline and the refractory relapse setting seems promising. This is in a disease that has not seen the approval of any new drugs in the frontline setting for high-risk MDS for almost 20 years outside of an oral formulation of decitabine. So certainly an area of significant unmet need. And I think there are ongoing discussions and with the regulatory agencies about moving to a frontline phase 3 study, which hopefully I think will allow us to fully explore the full potential of this drug and hopefully deliver an agent to patients who have significant unmet need, which can help them. I think the drug development in high-risk MDS has been quite challenging, but I think doing studies where we fully understand the dosing has been important. So I think the dose optimization part of the study was important to identify the best balance between safety and efficacy, and this was achieved by choosing the 3 milligram per kilogram dose. And I'm hoping that taking this dose forward to the phase 3 setting is gonna hopefully allow us to introduce a new drug to help patients with high-risk MDS.